we start with the first presenter, Dr. Anita Mani. Is she here? Okay. So she is presenting her paper on orbital myositis in young. Looks a bit incomplete. Young patients.
Good morning to all. Today I'll present an interesting case of orbital myositis in a young individual. My patient was a 23 years old male. He initially presented with a gradually progressive painful swelling of the left eyelid with chemosis of 15 days duration. The swelling decreased once he was managed with oral antibiotics and topical eye drops for 5 days. Then subsequently he reported with a complaint of double vision in the straight gaze, for which he reported to the hospital. So this was his initial presentation. When he presented with diplopia, his visual acuity was 6/6 both eyes, near vision N6 both eyes. The extraocular movements were full, free, and painless in all directions of gaze. So this is a picture showing extraocular movements. There was no restriction or any abnormal movement seen. However, the diplopia charting revealed diplopia in all gazes except the straight gaze. And diplopia increases in the superior gaze. So we investigated him thoroughly for the same. Systemic investigations and infectious disease panel did not reveal any abnormality. Thyroid function tests were within normal limits. Serum ACE was within normal limits, so it ruled out sarcoidosis. The autoimmune workup, complete autoimmune workup was also done. ANA, P-ANCA, C-ANCA, anti-RO-LA were negative. This MRI was done subsequently, which showed an enlarged, bulky superior rectus measuring around 3.5 mm. So a provisional diagnosis of idiopathic orbital inflammatory disease was made since all investigations were negative and presenting as orbital myositis. Since the superior rectus was bulky and impinging on the optic nerve, he was given a course of IV methylprednisolone for 3 days, followed by oral prednisolone in tapering doses. He showed a rapid response and there was improvement in diplopia and resolution over a period of 1 week. Repeat MRI at 2 weeks showed a decrease in edema around the extraocular muscles and normal optic nerves. Coming to the discussion, orbital myositis is a spectrum of idiopathic orbital inflammatory disease, earlier known as orbital pseudotumor. Generally presents in the 3rd to 4th decade, common in females, and recurrence is observed. One or more extraocular muscles are involved. Order of involvement medial, followed by lateral rectus, then superior and inferior, followed by obliques and levator. The muscle inflammation is often but not always there is involvement of the anterior tendon. It presents as diplopia exacerbated on ocular movement. There may be chemosis, conjunctival injection, and proptosis. The secondary causes include giant cell arteritis, SLE, granulomatosis with polyangiitis, sarcoidosis, Crohn's disease, malignancies, and infectious causes. All the investigations were negative in this patient. Herpes zoster, Lyme's disease, cysticercosis, and upper respiratory tractions infections are other infectious causes. There is a dramatic response to oral steroids. Relapse may be seen on tapering of steroids months or years after the episode. Immunosuppressants and biologicals may be used in steroid unresponsive and recalcitrant cases. Low-dose orbital irradiation in unresponsive cases. This is a unique case since it was a young individual, a male, and no secondary cause was detected. Thank you.
Thank you, Dr. Anita. I think it's a isolated myositis is as such a known entity. Yes. And we know idiopathic we label after excluding everything. So generally when there is only one muscle involved, we think of cysticercosis. So did you specifically look for cysticercosis in the muscle? Sometimes we can miss on the MRI and ultrasound helps.
Right, ma'am. We didn't specifically look on ultrasound was not specifically done, but MRI was done subsequently where the inflammation resolved. But we didn't specifically
no
look
cyst, or
no
you
cysts
did not
were
look
detected, ma'am.
Okay. All right. So the response was complete?
Response was complete. He had, within 2 to 3 days, his main complaint was diplopia. That resolved in 2 to 3 days. And within a week, he showed complete improvement.
All right. So what was unique about this case, as you said that
It
because
was
it's a
basically
known thing.
the presentation. Generally, we see in the older age groups. This was a young individual with no other comorbidities.
No, even in young individuals, you'd see,
Yes.
you come across, idiopathic orbital inflammatory disease where there is only one muscle
Single
involvement.
muscle.
And
Okay,
other
ma'am.
thing, you said that extraocular movements were normal and there was diplopia, so that is something which is contradictory. So did you go back and see whether there was any, extraocular motility problem also? After
Ma'am,
doing the diplopia charting, did you go back and see that like maybe it was missed, the
Ma'am,
movement thing?
restriction specifically maybe could not be, there, no gross restriction was made out on the extraocular movements.
All right. Any other question?
Are you still following up the patient? I mean, for
No
any
such.
relapse or something? I mean, how much time it has passed for the remission to?
Actually, being in armed forces, transferable job, sir. This was in my previous institute. So
Okay.
after that, I could not follow up this
And the
individual.
other thing was like I was also noting that the extraocular movements you mentioned they were fine, but in diplopia
Yes,
the
yes.
patient had diplopia, so that was something which was
Yes, yes,
kind
sir.
of.
So that was actually we could not. That's why we went in for an MRI and subsequent investigations.
Okay, maybe in the follow-up, if the patient relapse or something, we can go for the orbital ultrasound to rule out a single muscle
Right, right,
cysticercosis.
sir. I'll
Thank you.
try and follow up.
Thank you.